Our next abstract presenter is Ms. Shu-Nan Jessica Lee. Ms. Lee is presenting higher hospitalization rates in children born HIV-exposed and uninfected in British Columbia, Canada between 1990 and 2012. Ms. Lee is presenting from the University of British Columbia in Canada.
Hello everyone, my name is Jessica Lee. Thank you for the opportunity to present on higher hospitalization rates in children born HIV-exposed uninfected in British Columbia, Canada between 1990 and 2012. Globally, an estimated 14.8 million children are HIV-exposed but uninfected, or CHEU. In Canada, there are 200 to 250 HIV-exposed children born every year, the vast majority of whom are born uninfected as CHEU. Although they experience fewer adverse outcomes than children who do acquire HIV perinatally, there is growing evidence that CHEU are at increased risk of complications compared to children who are HIV unexposed and uninfected, or CHUU, born to HIV-negative mothers. Compared to CHEU experience a higher incidence of hospitalizations, infections, and worse clinical outcomes. Infants born to women living with HIV are also increasingly exposed to maternal antiretroviral therapy, or ART. The risk of hospitalization and infections among CHEU and the effects of antenatal exposure to ART have not been established in a Canadian setting. The purpose of our study was to assess hospitalization and infection outcomes among CHEU in British Columbia, Canada, while considering antenatal HIV and ART exposures on CHEU. We hypothesized that CHEU experienced more hospitalizations in the early years of life compared to their CHUU pairs, and that this difference may be modulated by maternal ART and maternal substance use. This retrospective controlled cohort study used data from health administrative databases. Maternal and child data were collected on CHEU and CHUU born in the province of British Columbia, Canada, between 1990 and 2012. CHEU and CHUU were matched 1 to 3 for age, sex, and maternal forward sortation area. The primary outcome of interest was any hospitalization, excluding those immediately related to delivery events, such as a single live-born boarding hospital. Other outcomes of interest included hospitalizations within the first month of life, within the first year of life, post-natal hospitalizations, defined as any hospitalization that occurred after 30 days of life, infection-related hospitalizations, and intensive care unit admissions, or ICU admissions. We determined the adjusted odds ratio between in utero HIV exposure, antenatal ART exposure, and child hospitalization outcomes via conditional logistic regression, adjusting for preterm birth. From 1990 to 2012, a total of 446 CHEU and 1,333 CHUU were included. Compared to CHUU, a higher proportion of CHEU were born preterm at 19%. CHEU also showed a greater prevalence of any hospitalization of 47%, hospitalization within the first month of life of 43%, and within the first year of life of 41%, as well as any ICU admissions at 29%. The most prevalent diagnosis of ICU admissions among CHEU was neonatal withdrawal symptoms from maternal use of drugs of addiction. Differences in the proportion of infection-related hospitalizations was not significant between CHEU and CHUU. Infection-related hospitalizations were primarily respiratory tract infections among both groups. After adjusting for preterm birth, CHEU experienced 2.3 times the odds of any hospitalization, 2.05 times the odds of hospitalizations within the first year of life, and 3.38 times the odds of ICU admissions compared to CHUU. With regard to the timing of maternal ART initiation, CHEU born to mothers who initiated ART pre-conception tended towards higher odds of any hospitalization with an adjusted odds ratio of 1.66, compared to CHEU born to mothers who initiated ART during pregnancy. However, Preconception ART tended towards a protective effect for ICU admissions with an adjusted odds ratio of 0.51. In British Columbia, CHEU experienced increased odds of hospitalization relative to control CHUU. A substantial number of them occurred within the first month of life among CHEU and were ICU admissions, particularly neonatal withdrawal symptoms. While it is likely the analysis was not sufficiently powered to detect a significant difference, our findings do suggest that earlier initiation of ART prior to conception may reduce the odds of ICU admission. Our results are limited by the lack of available data on other variables that may influence hospitalizations, including maternal pregnancy conditions, maternal HIV disease severity, medications other than ART, and socioeconomic and psychosocial factors. Women living with HIV receiving ART may be characteristically different from those who did not receive any ART, and may reflect the evolution in ART treatment guidelines from 1990 to 2012. In the early years of the study period, preconception initiation of ART may have indicated more advanced HIV disease. In the current era, women living with HIV who have not initiated ART preconception are more likely to have complex psychosocial factors and may be more affected by social determinants of health. Inferences of the cause of excess hospitalization and ICU outcomes remain limited due to these factors. In conclusion, our study provides population-level evidence within a Canadian context of increased odds of hospitalizations among CHEU. An important insight is the increased frequency and odds of ICU admissions, suggesting that CHEU experience more severe conditions independent of preterm birth. Preconception initiation of ART may mitigate some risk of ICU admissions. As the number of CHEU continues to rise in Canada and globally, further investigations of the multifactorial causes of hospitalizations are warranted. Our findings support careful monitoring among CHEU for adverse health outcomes and the importance of early initiation of maternal ART, and may inform future care strategies of CHEU to reduce hospitalizations. Thank you.